Hello, good afternoon, everyone, and thank you, all panelists and moderators, for allowing me for my presentation. So, in the next few minutes, I will take you through the complications which can happen after the PTCA and how to manage it. So, as we know, the coronary stent infection is a very rare but the underreported complication which can happen in 0.1% of the cases. It can occur both with the both drug-eluting stents and the bare metal stent, but though more common with the bare metal stent. So, although there is multiple factors which are related to that coronary stent infections, though we found out when there is infection of the valve of any valve, mitral, tricuspid, or aortic valve, or any infective endocarditis, there are more chances of the coronary stent infections. Along with it, there were any risk factors in the patients like diabetes, hypertension, obesity, COVID-19. They definitely aggravate the formation of the coronary stent infections. So we encountered about the 10 cases between 2020 to March 2024 with the varied presentations. Most of the patients present with a fever, along with the signs and symptoms of chest pain, and the cardiogenic and the septic shocks, along with the infective endocarditis. It was present infective endocarditis was present in the 60% of the cases. Initially, all the patients underwent that treatment by the IV antibiotics, and after the complete evaluation by the all kinds of that scans and the 2D echocardiography and the TE, they were taken for the re-exploration and the revasc. So we have done the removal of the stents along with the debridement of that cavity, abscess cavity, washed with the antibiotics with the vancomycins, and followed by the CABG. So in most of the cases, we resected the myocardial aneurysm in the 30% of the cases. Sometimes that epicardium and the myocardium or the pericardium was densely adheres. So we have removed the adhesions, and sometimes we have to reconstruct the coronary wall also for the bypass. So for that, the vein patch was used. The saphenous vein was the most common conduit used for it. So these are some angiographic pictures of the infected stents. So this is the first patient. First patient presented with us after the few weeks after the RCA stenting. It presented with the RCA aneurysm. And as you can see, seen in the angiographic pictures, the second patients underwent, as you can see in the first picture, there was CTO of the LCX. And the second picture, the stent was placed, and it was fully opened and fully revascularized, and TME3 flow was achieved. And after that, after the few weeks, he developed the left main aneurysm with the abscess formations. That abscess was going to the LVOT tract and communicating with the left atrium and going to the mitral valve, involving the mitral valve, causing the infective endocarditis and the vegetation formation on the mitral valve. So the third patient is also present after the RCA stenting, as you can see in the picture, and it led to the pseudoaneurysm formation. In fourth patients, it was after the LED stenting, there was pseudoaneurysm formation was there. And the fifth patient was that there were multiple LCX stents were there, which later on presented with a pseudoaneurysm formation. So these are after that, I will go through some TE images and the CT images. So there is a TE image of the first patient, and you can see that abscess cavity and the stent is visible. So I don't have any pointer. So this is the stent.
Oh, you have?
Okay.
Yeah. Just present this one.
Okay. So this is the stent which is visible. So the second patient, which is complicated by the infective endocarditis, there is a formation of the vegetation on the mitral valve, as you can see. And this is also visible in the 3D picture, 3D TE. So this is the first patient. You can see in the preoperative TE images, the stent is visible clearly by the arrow. And there's the same patients, there was compression of that RVOT, and there was compression of the tricuspid valve, so mild TR was also present. So this is the same patient. After the post-op patients, the cavity size has been reduced and stent has been extracted out, and after that the TR also vanished off. So these are the interruptive findings of these patients. The first patient, you can see that we have they lay open the cavity, and we have removed that stent. In the second patients, the L6 got infected by the infective endocarditis. We lay open the LVOT, and as you can see in the video, we have drained out all the pus, and we washed the cavity with the vancomycin and send it for the culture sensitivity. So after that, there was communication was present between the left atrium and the LVOT, which we closed it with a vein patch. and the vegetations and the mitral valve leaflets was removed, and when we did the mitral valve replacement. Since this complication happened after the left main, so we have to put the 3 grafts, one to the LAD, diagonal, and the LCA, that the circumflex. This was the extracted stent you can which is visible here. So this is the third patient, and there was already impending tamponade or impending pericardial effusion was there after the RCA stents. So we just opened out that cavity, lay opened, and we sent this mug for the culture sensitivity. So we found in our series, the early presentation was more common, living in less than 1 year, compared to the late presentations. Staph aureus was the most common bacteria which was involved. And the most of the patients presented after the LAD stenting or the RCA stenting, though we found the 2 cases with the LCX stenting also. In the 80% of the cases, the revasc was achieved, but in the 20% of the cases, there was a lot of dense adhesions and there was no graftal spots was there. So that's why we just washed with the antibiotic cavity and we patched that coronary wall. And since there was no graftal spots was there. So in the 90% of the cases, there was the infected phlegmos was there. And we found in our series that there was no mortality. So 2 patients required the multiple stent removal. And the 1 patient got complicated by the infective endocarditis, as I shown in the pictures and videos. So in the 70% of the patients, most of them were diabetic, the hypertensive, and the 3 patients were infected with the COVID-19 also. So the 4 cases we did by the off pump, and the 6 patients required the CPV. The 40% of the patients, they require the intra-aortic balloon pump support, which is removed on the 2nd or the 3rd post-operative day. The SVG was used as a main conduit for the bypass operations also, and for the reconstruction of the coronary walls also. All patients remain stable in the perioperative and the intraoperative period, and they were all discharged after the 7 days. So in the conclusion, the coronary stent infection is a highly fatal and a potentially preventable complication, and it is also underreported. And till now, there are only 79 cases reported there till the last meta-analysis of the Mr. Rama was published. In this, there were 79 cases was there. Before that, only 36 cases were reported. The surgical extraction of the coronary stent infections is a complex but a life-saving procedures. Infection control guidelines should be avoided to avoid such complications. So we should avoid the repeated use of that guide wires. We should take all aseptic and asepsis precautions while doing the PTCA, and we should avoid the PTCA doing in the infected patient when already bacteremia is there, or whether there any chance of the infected endocarditis in the patients. So we should avoid at that time. So all the risks and the benefits and the type of surgery should be customized carefully for each patient individually. So it needs a better characterization and definitely the customization for each patient. So these are my all references. Okay, thank you.
Thank you.